dysplastic kidney. في عنا cyst associated with systemic diseases such as tuberous sclerosis and von Hippel-Lindau syndrome. Now, simple cysts are usually they have a flat epithelium and they have a clear fluid content, and they are usually asymptomatic. When do we treat those patients? رينا سيست بيجي مريض بيقول حكي لي دكتور انا عندي رينا سيست، طب انا بدي اشيلها، طب ليش بدك تشيلها؟ ما بعرف، بخاف انها تتحول لكانسر. No, renal cysts they never they never transform into a malignancy, and they are rarely symptomatic. We treat them only if they start to produce symptoms such as pain. يعني إذا صار عندنا pain بالجهة اللي فيها الرينال سيست بنعملهم surgery. وإذا صار في عندنا bulge أو swelling in the area of the cyst، أو إذا صار في عندها complications such as hematuria أو pyuria. يعني إذا صارت في communication between the renal cyst and the pelvic calyceal system وبلشت تنزل دم أو بلشت تعمل infection وتنزل pus، هيك بنعمل surgery للrenal cyst. Otherwise we do not treat them. How do you diagnose them? Ultrasound. Ultrasound is very helpful. It can differentiate between solid and cystic lesions. عادة the cysts are anechoic, posterior acoustic enhancement, and sharply marginated with smooth walls. IVU كنا نعملها، ما بنعملها للرينال cyst، بنعملها renal tumors if can suspected. Renal angiography we don't do it. هلا أهم شيء بالرينال cyst you need to know what we call the Bosniak classification. Bosniak هو classification used to classify renal cyst according to the CT scan urinary tract with and without contrast. هلا number one is considered simple cyst، ما فيها septations، ما فيها classifications or solid components. Bosniak 2 فيها few septations, fine classifications, and usually it has sharp margins to differentiate it from the following classification. 2F is a subcategory of class 2 Bosniak. بيكون هون septations are multiple وبيكون في عنا minimal thickening of wall or septations, and it is usually intrarenal and they have measurable enhancement. هذا الكاتيجوري طلعت عشان they need follow up. عادة type 1 and type 2 we don't need to follow them up. Type 2F, type 3 and type 4 should be followed up and treated. Type 3 they have cystic mass with thickened irregular or smooth walls or septations وفي عنا measurable enhancement. Stage 4 في عنا enhancing soft tissue components, and usually this type has high percentage of being renal cell cancer. عادة stage 3 and stage 4 we treat them with a partial or radical nephrectomy. Treatment زي ما حكيت لكم it is not treated unless it was symptomatic or complicated, and عادة if you do aspiration it recurs unless you aspirate and inject a sclerosing agent such as 95% concentration alcohol. Excision is the best. عادة we do it in laparoscopic technique and it's a very easy half an hour procedure والrecurrence تبعها is very low. Now renal tumors نقسمها into benign and malignant. Malignant راح نحكي عن واحد اللي هو renal cell cancer، والbenign راح نحكي عن ال most common important benign renal tumors. To start with oncocytoma. Oncocytoma, they are benign renal epithelium neoplasm that arises from the intercalated cells of the collecting ducts. Now, this is the gross appearance of oncocytoma. It is usually unilateral. لازم تنتبهوا إنه it is the color is brownish but with a central scars but no necrosis. This is the central scar that you can see in the middle of the oncocytoma. This is very important. Then now it will present a pathognomic appearance on CT scan أو characteristic appearance on CT scan that usually distinguish it from other types of benign tumors or malignant renal cell cancer. This is what we call on CT scan. إذا شفتوا السنترال السنترال سكار اللي فرجيتكم إياهم. This is the appearance that it appears on a CT scan. This is طبعا هذا اللي عليه الإشارة. Okay. أنا كبير عشان هيك. شباب ما بعرف عم بيعلق معي، مش عم برضى يعمل برودكاستنج. سامعيني ولا لا؟
دكتور سامعين.
اوكي، انا راح اكمل شرح وراح ابعث لكم المحاضره لك محمد عشان تبعتها لزملائك. اوكي هلا oncocytoma, it has a appearance of what we call spoke wheel pattern on CT scan. نفس الصورة اللي فرجيتكم إياها بيكون spoke wheel appearance، يعني زي مقود السيارة الستيرينج، أو زي منظر الجنط تبع السيارة. It appears as spoke wheel appearance, and this is characteristic of oncocytoma. Okay, how do we treat those patients with oncocytoma? عادة we depend on the size. Those less than 4 centimeter are left untreated. حتى إذا كان more than 4 centimeter and is asymptomatic and you are 100% sure that this is an oncocytoma with a spoke wheel appearance, we do not treat them. بس عادة إحنا ما بنقدر نميز الأونكوسايتوما from malignant renal cell cancer. Therefore, we usually end up with nephrectomy, whether partial or radical nephrectomy. The second type of benign renal tumors is what we call angiomyolipoma. من اسمه angio blood vessels, myomuscles, and lipoma fat adipose tissues, and it is a benign renal tumor, and it is usually easily differentiated from malignant renal cell cancer by the presence of adipose or fat within the tumor. Usually they are multifocal and bilateral. 20% of them are associated with a systemic disease, which you all know called tuberous sclerosis. Usually the presentation, most of them are found incidental, mostly more than 50% on ultrasound and CT scan. They might present with a flank pain, mass, or painless hematuria. Now, we have a syndrome associated with angiomyolipoma called Wunderlich syndrome. Wunderlich syndrome is a syndrome presents with a massive life-threatening retroperitoneal spontaneous bleeding in 10% of those cases, and is usually seen in which category? In the pregnant woman. Now, how do we manage those patients? We always depend on the size. إذا كان the size is less than 4 centimeter and is asymptomatic, we leave them untreated. if it was symptomatic with a bleeding or more than 4 centimeter, عادة we do what we call selective arterial embolization. بنبعتها لطبيب الأشعة بفوت على الارتري اللي بغذيها وبيعملها embolization وبصير فيها shrinkage. Very rarely ممكن نعمل what we call emergency nephrectomy للوندرلي syndrome اللي شرحت لكم عنهم قبل. investigations ultrasound ببين الفات اللي فيها، CT scan كمان ببين الفات فيها, and it is usually easily differentiated from a renal cell cancer. Okay. The third type of benign renal tumor is renal adenoma. Renal adenoma are the most common form of benign renal tumor. It increases with age, and we have 3 types of renal adenoma: papillary, tubular, and alveolar. Okay. They now it is incidentally found on CT scan, and usually we end up in treating those patients with partial or radical nephrectomy, because I previously told you عادة any renal mass appearing on a CT scan or ultrasound other than angiomyolipoma usually is not differentiated whether it is a benign or a malignant renal tumor. Therefore, it is almost always يعني تتشخص فقط after we do a partial or radical nephrectomy. We can differentiate if it was benign or malignant, because most benign tumors appear as malignant in the appearance, except either can spoke wheel appearance for oncocytoma or the presence of fat within the tumor indicating angiomyolipoma. Now, this is the end of the benign renal tumors. I'd like to talk about one malignant important renal tumor اللي هو الرينال سيل كانسر. في أكثر من اسم للرينال سيل كانسر. في ناس بيسموها hypernephroma. It's a misnomer. كنا زمان نحكي عنها hypernephroma because we thought it originated from the adrenal gland. وفي اللي اكتشفها اسمه جراويتس فسموها جراويتس tumor. وفي because the most common subtype of renal cell cancer is the clear cell. ففي ناس بيسموها clear cell renal cell cancer. Now it is worldwide named as renal cell cancer. It is the commonest renal tumor, accounting for 85% of renal malignancy. Unfortunately, it is the most lethal of all urological tumors. Risk factors: smoking, men, gender, race. Black people are at higher rates of developing kidney cancer. الage عادة more than 50, in the peak of peaking at the age between 50 and 70. Those using on good diet with high consumption of vitamin A, C, E, fruits and vegetables are protective. Those with hypertension are at increased risk of developing renal cell cancer. Overuse of certain medications such as phenacetin, occupational diseases, occupational related to your job, such as asbestos and cadmium exposure, chronic kidney disease, long-term dialysis are at very high risk of developing renal cell cancer. The highest risk of developing renal cell cancer are seen in those patients with long-term dialysis for renal failure. Family history of kidney cancer also increase the risk of kidney cancer, and there are 2 anatomical risk factors to develop renal cell cancer. You need to all know it: horseshoe kidneys and polycystic kidney disease. Now, what are the causes or etiology of renal cell cancer? في genetic, we have 3 genetic causes of renal cell cancer. And a chromophobic renal cell cancer, it is due to result of loss of chromosome 17. في عندنا papillary variant of renal cell cancer, it is characterized by trisomy 7 and 17. وفي عندنا tuberous sclerosis complex, it is also associated with genetic renal cell cancer. Now, you need to know that the origin of renal cell cancer is the adenocarcinoma of the renal cortex, عادة arising from the epithelium of the proximal convoluted tubules. Usually it is unilateral. It is seen bilateral in genetic types or in von Hippel-Lindau disease. Okay. Now, the method of spread of renal cell cancer, في عنا three ways of spreading. Direct, it spreads to the adrenal gland, into the renal capsule, into the renal vein, into the vena cava, or all the way up into the right atrium. By lymphatics to the hilar and para-aortic lymph nodes, and hematogeneously, the most common site of metastasis is to the lung. ولازم تعرفوا كمان شغلة, the most common secondary malignancy or the most common organ metastatizing to the kidney secondary is the lung. Therefore, lung بحب الكدني والكدني بحب اللung. احفظوها دائما. Okay, very common question. Histologically, we classify them into five categories. The most common type is the conventional 70 to 80% أو بسميها clear cell, because it has glycogen and cholesterol containing cells. They appear as clear. Papillary 10 to 15%, chromophobic 5%, collecting duct أو بنسميها Bellini rare, and medullary cell is also rare. You need to know that the worst prognosis occurs in both Bellini or collecting duct and medullary cell. And إذا إجاكم سؤال young black sickle cell sufferers, عادة we find usually the medullary cell subtype of renal cell cancer. Grading, we grade it into grade 1, grade 2, grade 3, and 4. Grade 1 is well differentiated. Grade 2 is moderate. Grade 3 and 4 are poorly differentiated. The grading system for renal cell cancer is called Furman system. Now, staging is very important to know for both clinical and for written exam. بهمني T classification very 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 important. كلها موجودة بسلايدات راح ابعث لكم اياهم. TX primary tumor cannot be assessed. T0 there is no evidence of primary tumor. T1 اللي هو tumor لازم تحفظوها زي هيك. T1 and T2 are limited to the kidney. بس T1 is less than 7 centimeter. TG less than 4 centimeter. T1B is more than 4 but less than 7. T2 is a tumor limited to the kidney more than 7 centimeter. 7 to 10 centimeter, and T2B more than 10 centimeter. T3 زمان كنا نحكي it involves the adrenal gland in the T3A, but now adrenal gland احفظوها دائما is a very common question. Adrenal gland involvement in a renal cell cancer is considered T4 and not T3. هلا T3 هو tumor extending outside the kidney but not beyond the gyrotous fascia. Gyrotous fascia is a fascia أو بنسميها perinephric fascia. is seen. هلا كيف الكدني anatomically بيجي أول شيء الكدني، بعدين بغطيها كابسول بنسميها renal capsule، بعدين بيجي حواليها what we call perinephric fat، بعدين we have what we call the gyrotous fascia، بعدين after the gyrotous fascia we have what we call the paranephric fat. Therefore, T3 is a tumor extending beyond the kidney, but not beyond the gyrotous fascia. Tumor involving the perinephric fat. In T3B, it involves the renal vein or subdiaphragmatic inferior vena cava. T3C, tumor involves the supradiaphragmatic vena cava. T4, tumor invades beyond the gyrotous fascia or invading the adrenal gland. Now, the prognosis depends on the T classification and depends on the staging. Usually, T1A has the best survival rate, 5 year survival, accounting from 90 to 100%. Clinically, how do those patients present? زمان كنا نحكي the most common clinical presentation is hematuria. Now the most common clinical presentation is incidental. بشوفها على الالتراساوند، بشوفها بالسي تي سكان for a patient done for abdominal pain بيكتشفوا incidentally we found a renal cell cancer. Symptomatically, they present with hematuria, flank pain, mass, and less than 10% of them, they present with what we call the classical triad of hematuria, flank pain, and the mass. هلا في عندنا شيء اسمه paraneoplastic syndrome. It's very important to know. 10 to 40% of those patients they present with paraneoplastic syndrome. شو يعني paraneoplastic syndrome؟ هو عبارة عن syndromes associated with renal cell cancer عادة due to release of certain hormones. يعني البيشنتس هدول they present with anemia. Why? Because of hematuria or because of a chronic disease. They present with polycythemia. Why? Due to ectopic secretion of erythropoietin. Hypertension due to ectopic secretion of renin or due to renal artery compression or due to AV fistula. If they present with hypoglycemia due to ectopic secretion of insulin, إذا صار في عندنا ectopic secretion of ACTH, they present with Cushing. إذا صار عندهم ectopic secretion of parathyroid hormone-like substance, they present with hypercalcemia. If they release gonadotrophins, they present with gynecomastia, amenorrhea, reduced libido, and baldness. Therefore, أي hormone released, it produces a paraneoplastic syndrome. هلا في عندنا one of the types of paraneoplastic syndrome associated with renal cell cancer. It's very important to know. We call Stauffer syndrome. Stauffer syndrome هو those patients they present with elevated liver function due to hepatic dysfunction. عادة the cause is unknown, but it is usually treated by excising the tumor, whether by partial or radical nephrectomy. بس بتشيل التيومر بتروح الستاوفر syndrome. Investigation تعملهم CBC, kidney function, liver function, urine cytology, and urine analysis. Therefore, by investigations, the best modality of investigation or choice to diagnose a patient with a renal cell cancer is CT scan, urinary tract with IV contrast. هلا في ناس بيقول لك طب ليش ما ناخذ بايوبسي يا دكتور؟ ما ليش ما نقدر نميز بين benign and malignant؟ Now FNA أو CT guided FNA or CT guided biopsy is contraindicated in patients with suspected renal mass. In any renal mass, you do not do FNA except in two cases. First, if you are suspecting a renal abscess, يعني patient presented to you with a loin pain, clinically ill, fever, chills, and rigors, and you were suspecting an abscess, you go for a biopsy or FNA. The second indication, only indication, is a patient with known lymphoma and presented with secondary metastatic renal lymphoma, and you are suspecting lymphoma, you go for a biopsy is okay. Those are the only two indications for FNA in renal masses. Now, FNA has limited value. Why? ليش احنا ما بنحب نعملها؟ أول شيء because there is the risk of hemorrhage around 5%. اثنين في عندنا tumor spillage أو what you call tumor seeding. ثلاثة is false negative biopsy. يعني أنت بتاخذ البايوبسي بتطلع والله negative, this is not malignancy, and it was proven to be false. Therefore, we do not do FNA زي ما حكيت لكم unless in two cases suspected renal lymphoma or renal abscess. Treatment, how do you treat those patients? عادة we treat those patients according to the size, and we have multiple ways of treating them. We used to do it in open technique, and we still do it. We now most commonly use laparoscopic technique, and الدول اللي عندهم robot, they use it by robot assisted robotic approach of partial or radical nephrectomy. Now, the treatment depends on if the tumor is localized or metastatic. Usually localized disease, if it was less than 4 centimeter, it is done by partial nephrectomy. More than 4 centimeter is done by radical nephrectomy. هلا سؤالي لكم، مين بيعرف شو يعني معنى radical nephrectomy؟ شباب؟
دكتور إنه ما أقيم، يعني ما أقيم الكدني كلها، أقيم بس بارت من الكدني راديكال،
هذا
يعني مش
هاي بارشل نفركتومي. شو يعني راديكال نفركتومي؟
دكتور بشيل الكدني كامل مع السراوندينج فات.
Okay, you remove the kidney with the renal capsule, with the perinephric fat, with the gyrotous fascia and paranephric fat. This is one. إيش كمان؟
الليمف نودز كمان.
plus
اليوريتر.
minus lymph nodes, upper half of the ureter. إيش كمان؟
دكتور ممكن الادرينال gland إذا كانت involved.
Excellent. Bravo. Plus minus the adrenal gland. Not always the adrenal gland. Not always the lymph node. If we have involved lymph nodes, or if we have an involved adrenal gland, we do adrenalectomy or lymphadenectomy معها. Always you remove the kidney with the surrounding fat and gyrotous fascia, plus the upper half of the ureter. And هيك احنا بنميز بين simple and radical nephrectomy. الsimple nephrectomy بس بنشيل الكدني بدون اليوريتر، بدون surrounding capsules، بدون lymph nodes، وبدون الادرينال gland. اوكي. metastatic renal cell cancer عادة لازم تعرفوا انه renal cell cancer is usually كده نحكيها it is not radio sensitive at all. and in metastatic renal cell cancer إذا كنا بدنا نعمل palliation of symptoms for patients with pain and hematuria بنعملهم palliative nephrectomy. نستخدم لهم كنا immunotherapy. Now we use what we call molecular targeted therapy, because we found that those patients with renal cell cancer عادة they are very vascular, and they produce lots of vessels, and that اللي بتغذي الtumor. Therefore now we use molecular targeted therapies, very expensive therapies called sunitinib or sorafenib, and we use other types such as temsirolimus, everolimus, and bevacizumab. And one last important information is if a patient presented with a solitary metastasis after nephrectomy, you can go and do what we call metastasectomy حتى لو كانت بالbrain, and usually this is some type of palliative treatment rather than treatment for the tumor itself. في طبعا another two tumors اللي هم neuroblastoma nephroblastoma. باليورولوجي مش مطلوبين من عندكم، مطلوبين عندكم بالبيدياتريك سيرجري او بالبيدياتريكس بس تداوموا اطفال. في عندكم اسئله عن الرينال سيل كانسر؟
دكتور حكيت انه ال FNN is done in 2 cases، ايش هم؟
Only in 2 cases: renal lymphoma, suspected renal lymphoma و suspected renal abscess. renal lymphoma انت already بتعرفي بتاخذي history من البيشنت, and usually you know that this patient previously had lymphoma, therefore you suspect a renal lymphoma metastasis to the kidney. أو إذا patient presented to you with loin pain, fever, chills and rigors, and you were suspecting renal abscess. هدول the only 2 indications. ما عمركم تعملوا FNA لpatient with a renal mass unless in those 2 cases.
تمام دكتور، شكرا.
الله يعطيكم العافية، مع السلامة.